Hello, everyone. Good morning. Buenos dias. Muito bom dia a todos. Welcome to this World Webinar on Enhancing Awareness, Strengthening the Global Response to HTLV. In a few days, on the 10th of November, the HTLV community and civil society celebrates the World HTLV Day, and WHO is joining these celebrities as an opportunity to raise awareness on HTLV and to encourage countries to implement a public health response to this infection that leads to disability, social stigma, and also diminished quality of life. My name is Leandro Sereno. I'm an advisor at the Pan American Health Organization, WHO Regional Office for the Americas, and I'm going to moderate the first session of this webinar. Before we can start, I just would like to remind you that this webinar is, we are providing interpretation in English, Spanish, Portuguese, and French. So feel free to select the language of your preference using the Zoom platform. And also I'd like to remember you that this webinar is being recorded and will later be available on WHO's PAHOS platforms and social medias for you to watch again. And so to start now with the meeting, I would like to invite for the welcoming message, Dr. Jerome Solomon, who is the Assistant Director General for Universal Health Coverage, Communicable and Non-Communicable Diseases at WHO. Dr. Solomon, you have the floor.
Thank you so much, Leandro. Dear colleagues and friends, greetings, good morning and good afternoon. Today is World HTLV Day. HTLV, or human T lymphotropic virus, is a virus that can cause certain types of cancer and is transmitted primarily through blood, breast milk, and semen. Despite the significant burden of HTLV and its associated diseases, with an estimated 5 to 10 million people affected, awareness about the virus remains limited worldwide. The lack of awareness combined with poor data prevents timely diagnosis, affects the quality of care, and delays the development and the implementation of health policies. WHO is committed to building a more effective and robust response to HTLV. In today's webinar, we will share some of WHO's plans to achieve this goal. We will hear best practices from pioneering countries in the WHO Americas region through the work underway with PAHO, and hear details of the first guideline development process for HTLV planned at the global level. We will hear from leaders in the field making progress to streamline diagnosis and testing services, as well as promoting efforts to prevent mother-to-child transmission. It's so encouraging to see so many of you here today. We need multiple sectors and perspectives to succeed. I would particularly like to express appreciation for leaders in the community who are working tirelessly to raise awareness and mobilize efforts to address HTLV. A special thanks goes to Fatoumata Diallo, who today is representing many of those affected by HTLV by sharing her personal experience as a woman living with HTLV. Your powerful interventions and insights are so central to our work. Many challenges remain. We still need more research to improve diagnostics, prevention, and care, and we need to ensure we do more with the tools and knowledge we have today. I want to take this opportunity to reaffirm WHO's commitment to strengthening the global response to HTLV. By working together across civil society, the scientific community, healthcare professionals, and policymakers, we can drive meaningful change. I wish us all a fruitful webinar and much success in our collective efforts to address HTLV. Thank you.
Thank you so much, Dr. Solomon, for your message. We're going to hear from the civil society, from the people most affected by this infection. And I would like to invite Mrs. Fatoumata Diallo, a representative from civil society, to also share some opening remarks. Fatoumata, you have the floor, please.
Okay, thank you for the opportunity. I would like to say good morning, afternoon, or evening, depending on where you are in the world. My name is Fatoumata Diallo. I'm a mother of two. I am currently completing a master's in public health, and I have a diagnosis of HTLV. I would like to start my story with the well-known saying, knowledge is power. Knowledge grants people to make informed decisions about their care, their life choices, and the health of their children. This is important in HTLV. My story with HTLV started 22 years ago, when I was tested by coincidence in the clinic. I was already a mother at the time that my daughter, who was 9 years old, was also found to have the virus. She was born in Portugal. At that time, there was no testing offered for the virus, and I went to the popular saying, breast is best. It's well known in the case of HTLV, breast is not the best. Like many mothers, I did what I felt was right for her. I breastfed her. When I found out I had the virus in 2002, it was shocking to find the lack of knowledge on HTLV in healthcare. So it was sad to realize that the simple act of breastfeeding her, something we are encouraged to do, put her life at risk. Upon getting this life-changing news, I went ahead and typed into the Google, something you should never do. Most of the information I found linked HTLV to HIV. And having grown up in the 80s HIV frenzy, I knew very well what this meant. I was going to die. I did not have much time. That was my reasoning. Very little was known at the time about HTLV, and despite I was given a lot of reassurance by healthcare professionals, it was difficult to ignore the information that HTLV was a close cousin of HIV. The diagnosis changed the path of my life completely. I became a do everything as soon as possible person. I avoided romantic relationships, and I lived life on a day-to-day basis. After 10 years or so, I did eventually get married. And I had my second daughter, armed with knowledge I now had about the increased risk of transmission through breast milk. I went to the new saying that fed is best. She was solely bottle fed, and after her first birthday, she thankfully tested negative for HTLV. At the time, I asked my family members to also get tested, but they were reluctant. They had no awareness of its impact and fear of the cultural stigma which comes with the virus. My mother did not get tested until, unfortunately, she fell ill in December 2023 with late-stage leukemia, which was found to be due to the lifelong trajectory of having HTLV. My mother passed away peacefully on the 1st of April 2024 in my home. The once taboo issue quickly became a matter of duty of care to make people aware of the silent but deadly virus. Following my mother's passing, my family became more aware of HTLV and the real effects it can have. My constant nagging and this experience motivated many of them to get tested. We have since found that out of the 7 siblings, I, my sister, my 2 brothers have the virus. We have also found that my maternal uncle, my sister-in-law, and my 12-year-old nephew also have the virus. Through tracking how this could have been passed, it appears that the virus was present at least as far back as my great-grandmother, who passed it on to my grandmother, and on to my mother, onto me, and onto my eldest daughter, all through breastfeeding. That is 5 generations. So when I say that knowledge is power, for my family is literally the difference between life and death, a healthy life and a potentially limited life. I'm thankful for all the research that has got us to this point, but I believe we are far behind where we need to be. There is still a lack of testing for pregnant women from high-risk backgrounds. This small effort could ensure that the virus is not passed on to their babies. Also, there is urgent need to test blood donors. We are still not sure why some people with HTLV develop diseases and others do not. Testing for this virus in people who look like me and come from areas where this virus is common needs to be a routine. The reality is that HTLV1 affects real people like me and my family with real stories. We must spread awareness and accelerate the research on HTLV. Doing so, we can save the next generation. Thank you.
Thank you so much, Fatoumata, for sharing this perspective from the patient, the people living with HTLV, and this lived experience with the disease. I think that's precisely what should encourage us and out of us to continue and to strengthen the activities and the efforts against the HTLV infection. Thank you so much. And moving on with the agenda. I would like to invite for the next presenter, Dr. Carolina Rosadas. Carolina is a researcher on HTLV. She has been an advocate for HTLV awareness for many years, and more recently, she's working as a consultant for WHO, leading the efforts and activities on HTLV. And she's going to share some of the activities that WHO is working on to promote HTLV. Carolina, you have the floor. Thank you.
Thank you, Leandro. Thank you so much, everyone, for joining us today to celebrate World HTLV Day. And thank you, Fatoumata, for sharing your experience. So today we are discussing enhancing awareness and strengthening the global response to HTLV. And I think that this is very much aligned with what WHO is planning for HTLV. So we really need to increase awareness, as Fatoumata highlighted, to include HTLV in the agenda. And this, I'm sure, will make that the research agenda will be accelerated and also the policies to HTLV. So this infection is affecting at least 5 to 10 million people in the world. And we know that these numbers are probably underestimated because we still have no reliable data for prevalence in many countries. And most of those living with HTLV, they are in areas with low human development index. So HTLV infection also contributes to deepen health inequities. As it was said previously, HTLV is transmitted by sexual, parental, and vertical routes, mainly by breastfeeding. So we know that most people living with HTLV will be asymptomatic. However, we also know now that HTLV1 infection is associated with increased risk of all-cause mortality. This infection can also cause a very aggressive type of blood cancer called adult cell leukemia or lymphoma, and many inflammatory conditions, including a neurological disease called HTLV1-associated myelopathy that greatly impacts the patient's quality of life. We also have the impact on co-infections and the socioeconomic impact, as the stigma, for example. There is still no treatment for HTLV, so prevention is crucial. In 2019, WHO organized a technical meeting to discuss the public health impacts of HTLV1 infection, and this resulted in the publication in 2020 of the technical report on HTLV and a fact sheet. In 2022, HTLV was included in the strategic planning for sexually transmitted infection, and during the past years, WHO has been engaging more with civil and scientific society and also trying to identify opportunities to include HTLV in the agenda, as we are doing today with this webinar. But we understand that this response could be quicker and more effective. So now WHO has established a steering committee for HTLV guidance, and we are launching the guideline development process. So we are still, you can pass to the next slides, please. So we are still at early stages of the guideline development process for HTLV. So we are at the planning and consultation phase, but we aim to have the guidelines ready by the end of 2025. And throughout the whole process of guideline development, we will have a lot of different opportunities to collaborate with policymakers, civil and scientific societies across the regions. So we do expect to have a strong collaboration between different players. And we also aim to increase collaboration with WHO countries and regional offices to support them as they build their local and regional response to HLV. And another critical point is to keep raising awareness about HLV and also driving investments and the response in strategic areas across the countries, which include, for example, blood safety, prevention of mother-to-child transmission, and diagnostics. So I'm very excited to be starting this process, and I'm looking forward to collaborate with you all. So please don't hesitate to send me questions, suggestions, and to share your experiences by email. Thank you so much.
Thank you so much, Carolina, for sharing this quick overview on the activities that WHO is working. And for the next presentation, it's on my account. Let me share my slides. Okay, I hope you can see my screen. And sorry. Okay. And okay. So yes, for this presentation, I'm really pleased to announce that PAHO is launching today this technical note on good practices to prevent mother-to-child transmission of HTLV1 in the context of the Initiative for the Elimination of Mother-to-Child Transmission, or EMTCT Plus initiative, as we call here in the region. This is the result of several months of discussions, interactions with academia, with civil society, and with program managers across the Americas and beyond to be able to compile some of the key interventions that we believe are crucial to reduce the mother-to-child transmission and to increase awareness on HTLV in the health system in the region. This document is available from today on PAHO's website, and I'm going to leave the link at the end, but I just would like to give a quick overview on the document. But before, I would like to remind on the activities that PAHO has been doing to promote HTLV in the region. After the meeting, the technical meeting that WHO held in 2019, as mentioned by Carolina, PAHO has started working and responding to this call by promoting awareness. Now, so we have here, we promoted and organized a series of webinars and meetings to promote HTLV, the different perspectives of HTLV, focusing on mother-to-child transmission that have been identified as one of the priorities here for the Americas. Out of these meetings, we published a report with the general discussions and conclusions. They are also available, and we've been also promoting some technical meetings across the region, again, to promote awareness and to encourage countries to start responding to this infection. And more recently, as I mentioned, that we're launching today, the development of this technical note. And the objective of this, we have two specific objectives. That's to compile the evidence on interventions that are available to prevent the EMTCT of HTLV1, and also to share good practices that countries are already implementing. So we were able to identify that several countries in our regions are, and also beyond, but specifically in the Americas, are already implementing strategies and interventions to prevent HTLV and EMTCT of HTLV. So the idea was also to share these experiences, these good practices, to encourage other countries to do. And the ultimate objective is also to support our member states, PAHO member states, in developing their national responses to HTLV, focusing on the vertical transmission and the elimination and prevention of vertical transmission. The audience is the national program managers, healthcare professionals, but also civil society to support the advocacy activities in the countries. So we organized this document in 10 main action points that ranges from awareness, training, testing, sharing of information, and etc. I'm not going through each of these actions. You may find more details on the document itself, but we wanted to cover not only interventions specifically to eliminate or to prevent mother-to-child transmission, but also interventions that could be used, the MCA, the Mother and Child Health Platform, as an opportunity to increase awareness for HTLV in general. So, but I would like to highlight the core interventions here. That's the core interventions that we're calling, that are the interventions available to prevent the mother-to-child transmission. After you screen the pregnant woman, identify the case, these interventions, as of today, they are focusing on the suspension of breastfeeding and alternative nutrition options for the baby. And this, for all these action points, the document includes the rationale and the evidence for the inclusion of this action, these interventions. We also have included some suggestions on the strategies for the implementation of these interventions. And also, as I mentioned, we have examples and good practices for countries that are already implementing these interventions. And as I mentioned, we want to integrate HTLV in the elimination of mother-to-child transmission. Here in the region, we have the MTCT Plus initiative. Other regions may call it the triple elimination. We call it the MTCT Plus because beyond, in addition to HIV, syphilis, and hepatitis B, we also have including Chagas, and we are now further expanding to include HTLV. But we have now so far 11 countries that have been validated for the dual elimination of HIV and syphilis with strong lessons learned, specifically the interprogrammatic implementation and the high political commitment that allow them to achieve these validations. And we want to leverage on this, these lessons learned and leverage on this platform of the MTCT Plus initiative to further integrate HTLV focusing on the elimination of mother-to-child transmission. And to do that, and to align the HTLV, with the MTCT Plus initiative, we are proposing also some interim targets. Two sets of targets, one the impact target and the other programmatic objectives, to be aligned with the MTCT, as all the other 4 diseases, they have specific targets and objectives. And for HTLV, we are proposing a reduction of mother-to-child transmission to below 5%, a mother-to-child transmission rate. And that's based on a systematic review of the literature and also some real-life experiences for countries that were able to reduce. So we believe that achieving a mother-to-child transmission rate below 5% is possible, and it has been already achieved in many places, in many territories, after the active implementation of interventions to prevent. But again, these are interim objects and targets, and we are going to update and review it as more evidence are generated. And in terms of the programmatic objectives for all the other diseases as well, they are related to coverage of services. And we are proposing here for HTLV the coverage of antenatal screening, the coverage for the core intervention of the replacement feeding, and also the coverage of the follow-up and screening of the babies and the children as an opportunity to ensure that they are referred and linked to care and for a proper follow-up. And this, as I mentioned, was to align with the other disease already in the elimination initiative, the MTCT Plus initiative. And here just an overview to show with all the targets and how they interact, how they are aligned, okay? So as countries are implementing their programs for HIV, for syphilis, for hepatitis, they could also consider integrating HTLV as well and follow and try to achieve the targets. The document also provides some additional information, like for some examples of awareness campaigns that countries were doing here in the region. Some also additional resources from countries, from academia, and from civil society that others could also review and use. Also, it's available for use in other countries as well. And also for the perspective, what are the next steps? So we are launching the document today. This is also part of the dissemination efforts that we're doing for this document, for this technical note. So, but we are further disseminating here in the region to program managers, civil society, all other stakeholders engaged in HTLV. As I mentioned, we are going, as countries expand the response and generate more evidence, we are going to reassess and review the interim targets that have been proposed. So we, in the future, in the near future, we may be able to confirm, validate, or review these targets. But I do believe that with the evidence and the information that we have already, I think they are enough to start implementing public health response to HTLV in the countries here in the Americas and also beyond. We are going to continue now to promote discussions about HTLV and to encourage countries to build a public health agenda on HTLV here in the region. We are going to support countries. PAHO is prepared and ready, as well as WHO, to support countries as they design and implement the national responses to HTLV. And as Carolina mentioned, WHO is now engaged on developing formal recommendations and guidelines on HTLV, and PAHO is also ready and available to support this process. And so I would like just to comment and to acknowledge here and to thank a series of colleagues from PAHO and WHO and also external collaborators that work and interact during the development of this document. And it's already available on PAHO's website, and you can access here and using this QR code, and I invite everyone here to access and review the document. Thank you so much. So now I would like to give the moderation to Carolina Rosadas, who is going to moderate through the next session. Thank you, Carolina. You have the floor.
Thank you, Leandro. So now I would like to invite Professor Toshiki Watanabe from Japan. He's Emeritus Professor of the University of Tokyo and Professor at Santa Mariana University School of Medicine, and also the President of the Japanese Society of HLV1 and Associated Disease. Thank you so much, Professor Watanabe, for joining us today.
Thank you for your introduction. My name is Toshiki Watanabe, and I would like to thank organizers for giving me the opportunity to present at this webinar. Today, I would like to talk about the anti-HTLV1 measures in Japan and the current situation regarding the HTLV1 in Japan. So I will start my slides, okay? I will share my slides. Okay.
Yeah, they're perfect.
Okay. So first, here is an estimate of the how many people in Japan are currently infected with HTLV1. In Japan, the nationwide estimate of the number of infected people is based on the number of antibody-positive carriers obtained from blood donors at Japanese Red Cross. The data shown on the slide is from 1990 and 2010. As you can see here, in 1990, it was estimated that there were 1.2 million infected people. But by 2010, this had decreased by about 10% to around 1.08 million. The next slide shows the most recent data, an estimate of the number of people infected in 2020. As you can see here, it was calculated to be around 660,000. Although it appears that there has been a significant decrease over the past 10 years, it is thought that this is largely because of blood donation avoidance and the general healthy donor effect, and it is judged to be an underestimate. In any case, it is thought that the trend of the gradual decrease is certain. This slide shows this slide shows the background to the Prime Minister's office formulation of the HTLV-1 comprehensive measures in 2010. It is a very detailed description, so it may be difficult to understand, but it shows how HTLV-1 specialists and patients groups for HTLV-1 related diseases worked together to lobby politicians, and after about 10 years, the government finally formulated comprehensive measures. This slide shows a hot photo from the meeting at the Prime Minister's office where the HTLV-1 comprehensive measures were decided in the presence of Prime Minister. I am also in the photo on the right. On October 5th, 2010, the government decided to include HTLV-1 antibody testing in the nationwide antenatal checkups. And on December 20th, the HTLV-1 comprehensive measures were issued. As a part of these government initiatives, guidelines for diagnosing HTLV-1 infection and manuals for preventing mother-to-child transmission have been prepared. And this is a promotion structure and the priority measures are shown in this slide. And this is we prepared the guidelines for the diagnosis of HTLV-1 infection. This is the Japanese guideline, third edition. And this is a manual for prevention or preventing mother-to-child transmission. So we have a manual. On the left side, you can see in the Japanese. And we usually recommend to stop breastfeeding, and the result of the this slide shows the extent to mother-to-child transmission has been suppressed by introducing HTLV-1 antibody testing for all pregnant women and providing breastfeeding guidance. It is thought that the breastfeeding guidance for the pregnant women with positive antibodies has almost completely suppressed mother-to-child transmission via breast milk. The mother-to-child transmission rate shown on the slide, 3%. This means that even if we completely stop the breastfeeding, there remains 3% of mother-to-child transmission. To add some data for the mother-to-child transmission, Japanese data shows that HTLV-1 positive mother transmit the baby at the rate of 20%. So 1 in 5 children will be infected by breastfeeding. So next, I will talk about the actual situation of the number of the people infected horizontally in Japan. This slide shows the data that appear from a paper we published in the Lancet Infectious Disease in 2016. By analyzing blood donors over time, we were able to determine the number of people who had become antibody positive, and based on this, we estimated the number of people infected horizontally each year. As a result, we estimated that around 2,200 cases of horizontal transmission occur in each year. Considering the number of mother-to-child transmission is currently less than 100 cases per year, this is a very large number in Japan. I have now shown you the data of infection in Japan. As you can see, the number of mother-to-child transmission is less than 100 cases per year. And the number of cases of horizontal transmission is about 5,000. And transmission by blood transfusion is completely blocked since 1986 in Japan. This concludes my presentation. Thank you for listening.
Thank you so much, Professor Watanabe. I think it's quite stimulating to see the results from Japan. And I'm sure this is also very exciting to see that this is very aligned with what PAHO has been proposing as targets. So we hope other countries will follow as well. So now to keep the meeting going, I will invite Dr. Pamela Gaspar from the Brazilian Ministry of Health to present on the elimination of HTLV-1 mother-to-child transmission in Brazil. Thank you, Pamela, for joining us today.
Thank you, Carolina. I'm just trying to put my slides. Can please allow me the organization?
Maybe Professor Watanabe needs to stop sharing.
Okay.
Go ahead.
Thank you, Professor.
I stopped, okay? Okay.
Yes.
Yeah,
Can you see my slides now?
Yeah.
Okay.
Oh, thank you. So, hello, everyone. Good afternoon, good evening, and good morning. Thank you for the invitation. It's a really pleasure to be here, and congratulations for this great event. So today I'm going to talk about Brazil and the initiative for the elimination of HTLV-1 mother-to-child transmission. So Brazil is a huge country with more than 200 million inhabitants. We have 5 main regions with 27 federal units and a lot of municipalities. And it is estimated more than 1 million people live with HTLV in Brazil, estimated by blood donor, the same way that Japan did. We have our healthcare national system, we call SUS, that it's based on decentralized universal access. And the federal, state, and municipal levels are responsible for prevention, diagnostic care, and surveillance of HTLV. To improve the knowledge of the HTLV epidemiological data, we are performing a population-based study in partnership with Moinhos de Vento and ProAdSUS with parturiente women, testing both blood samples for HIV, syphilis, viral hepatitis B and C, and HTLV. Until now, a half of the sample was collected and tested, and the preliminary prevalence is 0.11%, and we are expecting that this prevalence will be higher until the end of this study. We also established HTLV as a notifiable disease. It is under implementation, and we believe the national surveillance data will better guide public policies and improve the quality of care. The notification will be for HTLV, HTLV in pregnant women, and exposed children to HTLV, as happened with HIV and syphilis. We are also implementing our screening program for all pregnant women doing antenatal care. We have around 2.5 million of pregnant women per year. We have already HIV, syphilis, hepatitis B and C testing, and we are implementing HTLV, laboratorial triage, and really important confirmatory testing. And there is some research, Professor Edel and Professor Carlos Brits, that are under development the HTLV rapid test. So it will be very important when we can have visuals in Brazil, as we have for syphilis, for HIV, and viral hepatitis. But until there, we're gonna have the laboratorial testing. And nowadays, the main challenge is to define what is the safest delivery method for prevention of HTLV mother-to-child transmission. Is vaginal or cesarean? So it's a question that we need to answer here to put on our guidelines. Regarding the supplies, we have already provided for prevention of mother-to-child transmission condoms, internal and external, cabergoline, and infant formula as the guideline recommendation to avoid breastfeeding. And we have a new initiative. It's a national program a national government commitment involving not only health sectors, but also all sectors that address social determinants. We saw the deployment of Fatoumata saying how social determinant is HTLV. The aim is to eliminate those socially determined diseases by 2030, including vertical transmitted infection like HTLV, syphilis, HIV, hepatitis B, and Chagas disease. Here is the launch of the Healthily Brazil program. We're very happy to have Dr. Tredos here and Dr. Jarbas here with our Minister of Health, Dr. Anísia Trindade. And we have the meeting, Adriano Oliveira, that gave us an emotional testimonial about living with HIV. It was really great to have Adriano with us. She and everybody from HIV Vida are good partners for us here in the Ministry of Health. We have also our subnational certification of mother to child transmitted program. It is inspired by PAHO and WHO certification initiative and process. We have already 110 municipalities already certified for HIV or for syphilis. This year, we're gonna have more certification, and now we are including hepatitis B. And the next year, we're gonna have the certification of HTLV for the elimination of mother to child transmission. And we are very happy to see Leandro showing all the goals, the process and impact. So we can now include on our national guide for certification and elimination process. And finally, this is an initiative to bring HTLV out of invisibility. We believe that information is the best way to prevention. So we are conducting workshops with civil society, scientists, professionals, managers, and healthcare professionals to explain all over the country what is HTLV. And we performed the campaign for the National Day, is 23 March, and the International HTLV Day, as WHO is doing. We do the guidelines, course, informative materials, and includes HTLV in all STI and public health congress to increase the dissemination of the information. All of this was possible because we have a strong collaboration with scientific and civil society, municipalities and states, governments, healthcare professionals, PAHO, and WHO. Muito obrigada. Thank you, everyone.
Thank you, Pamela. It's very good to see the response in Brazil. So congratulations to you and all the team for these efforts. And I hope you have very good, successful history to tell us next year. So I would like to invite now Kate Davison from the NHS Blood and Transplants and UK HSA Epidemiology Unit. So Kate will talk about blood safety and blood donor screening. Thank you so much, Katie. You are mute, Katie.
Thank you. Can you see my slides?
Yeah, perfect.
Brilliant. Okay, lovely. Thank you very much. Hello, everyone. And thank you to the organisers for the invitation to speak today. So this initial slide here outlines the timeline of HTLV screening of blood donations across the 4 UK blood services. The UK is a low prevalence country for HTLV, and blood donation screening was first implemented in 2002. The rationale was based on evidence in the 1990s of transmission in the UK through transfusion of non-leukodepleted components. The very serious nature of HTLV-associated disease was a concern, and there was evidence of infection in blood donors. So while initially it was deemed not cost-effective, the introduction of Hep C NAT testing in 1999 brought with it a system to pool blood donations. So that reduced cost with fewer initial tests and fewer confirmatory tests with higher specificity of the pooled approach. So leukodepletion was in place in the UK from 1999, but the data confirming the effectiveness for HTLV was lacking at the time. Sorry, next slide. Oops, sorry, get back. Sorry about that. So in 2013, HTLV screening moved from pooled to individual testing, utilising a fully automated serological platform for the first time, but this was at a higher cost. So we reviewed it in 2015 and found there was extremely low HTLV rates, rare seroconversions, and no transmission via leukodepleted blood components. So that prompted a re-evaluation of the UK's screening needs. So by 2017, England adjusted its screening strategy to focus on first-time donors and those donating non-leukodepleted products, while Scotland adopted a similar policy from 2022. Leukodepletion was considered highly effective, and this strategy was highly precautionary to prevent prevalence increasing again in the donor population, so to try and minimise the risk arising in the event of a leukodepletion failure. So surveillance follow-up and a system for referral for onward care were in place from the start of testing in the UK. Across the UK, we collect the demographic information from all donors at registration and at every donation, providing denominators for monitoring purposes. Screening results are reported to estimate specificity of the assays that we use, and every reactive donation is confirmed and typed. All positive donations are followed up with a clinical interview to identify risk factors for HTLV and referred on to one of 4 HTLV specialist clinics in the UK for advice, support, further diagnosis and care. The data about positive blood donors are collated by the epidemiology team working across blood services and the GHSS, and we also coordinate the HTLV National Register, which has been recruiting people with HTLV for long-term follow-up in collaboration with the blood services and the HTLV specialist centres since 2002. So my next slide shows the data on HTLV positive blood donations in the UK from 2002 to 2023, with a total of 311 confirmed cases. It illustrates the 3 main screening phases: the pool screening from 2002, the individual donation screening from 2013, and the targeted screening for first-time and non-leukodepleted donations from 2017 onwards. So the number of cases are in bars and the rates are in lines. So as is typical when a test is first introduced for blood donations, screening initially picks up previously undiagnosed infections in both first-time and repeat donors. So as these HTLV positive donations were removed from the blood supply, the newly diagnosed infections we picked up were generally in first-time donors or those previously tested, with very few numbers of seroconversions and repeat donors. So for the last 5 years, we've detected no more than 12 positives in a year, with rates to around 8 per 100,000 first-time donors. And there's no trend associated with the change in this screening strategy. So here, the data for the last 5 years. So we've compared rates for males and females across age groups. Overall rates are higher among female donors than male donors, but as you see, this is not across all the age groups, and there's some evidence of higher prevalence in the male donors over 55. Interviews with our positive donors have established that most cases are associated with endemic countries acquired through either vertical or sexual transmission. And these countries have included those of the Caribbean, Africa, as well as Iran and Japan. An unexpected finding of HTLV in blood donors was identifying positive donors who practiced religious cutting rituals. So there's 3 in the last 5 years, and we've identified 7 in total. And this prompted work by colleagues at St Mary's to educate communities into safer practices. So for my last slide, just to summarise that the UK blood services have been testing for HTLV since 2002. We've identified 311 cases in donors and who have been referred on for care. So screening continues, and even though at a low rate, we still identify positive HTLV asymptomatic individuals who would otherwise go undetected, helping people get HTLV support and avoid passing on HTLV to others. Screening is highly precautionary, as I mentioned, just in case leukodepletion falls below 100%. Cases continue to be recruited to the HTLV National Register cohort for onward follow-up. So there's no other routine screening for HTLV in the UK, including antenatal, but selective screening in pregnancy is under consideration. Thank you for listening.
Thank you, Katie. It's quite interesting to see the different strategies that we had in the UK over time to guarantee the blood safety, and also all the work that we have been doing to guarantee as well the care of the blood donors that are identified. Thank you so much. So now I would like to invite Professor Peter Figueroa from the University of West Indies in Jamaica to tell us how we can integrate HLV in the context of sexually transmitted infections. Thank you so much, Professor Peter.
Thank you, Carolina, and thanks to the organizers for inviting me to speak on HTLV1 as a sexually transmitted infection. We all know that STIs are common. There are over 30 different sexually transmitted infections. And if we just focus on the four most common curable STIs, chlamydia, gonorrhea, syphilis, and trichomonas, there are more than 1 million new infections of these four curable STIs every day worldwide. Now, we know that different STIs often travel together. So if you find one sexually transmitted infection in a person, then it is quite possible that they may have another STI. HTLV1 is usually asymptomatic. So if you do not test, you will not identify it. So what we're looking at is for persons who are treating STIs, any STI, then that health provider needs to remember that they should be considering a test for HTLV1. In Jamaica, when we did a survey of our persons attending our STD clinic, we found a prevalence of 5 to 7% actually had HTLV1. So it's very important that we consider doing testing for HTLV1 infection in persons presenting with a STI. They're not going to be asymptomatic usually at that time. Unfortunately, many of our health providers are not well informed about HTLV1. Now, sexual transmission of HTLV1 occurs more readily from the male to female than from a female to a male. Therefore, the prevalence tends to be higher among female adults than male adults, and it increases by age. In studies done in Jamaica, we found that women with early onset of sexual activity and multiple sex partners were more likely to have HTLV1 infection. We also found a high prevalence in female sex workers. So it's important for persons treating STIs to bear this in mind. Now, especially if you have a STI in a woman of reproductive age, it becomes even more important to test for HTLV1, because we know that mother-to-child transmission through breastfeeding, if that woman gets pregnant, she has a good probability of passing her infection to her child. And really, hearing the first speaker talk about 5 generations of her family being infected through mother-to-child transmission just shows you the importance of identifying pregnant women or women of reproductive age who may have HTLV1. The prevalence among antenatal clinic attenders in Jamaica was found to be 2 to 3%. In Haiti, 4%. So we really do need to introduce testing among antenatal clinic attenders for HTLV1, and we're hoping to initiate this in a pilot study in Jamaica over the next year. Once testing takes place, whether of blood donors or antenatal clinic attenders, it's very important to counsel the person, but then also to seek and counsel and test their sexual partners. We need to better promote condom use because this is an important way of preventing STIs, including HTLV1. So we do need to increase awareness and knowledge of HTLV1 as a sexually transmitted infection. We have to improve our knowledge among our doctors, other health providers, our patients, and the public. Prevalence of HTLV1 is higher among persons with STIs, so we must test them for HTLV1 so we can advance the likelihood of further reducing transmission. Unless we reduce new infections of HTLV1, we will continue to see persons of older age developing adult T-cell lymphoma and HTLV1 associated myeloma, as well as other conditions. And we really should take more steps to prevent these. Thank you.
Thank you, Professor Peter. I think two very key points are increasing knowledge among healthcare professionals and the integration of HLV into other initiatives. Thank you so much for your comments. I would like to ask for the technical team to share the video from Philippa Hetzel from the National Reference Laboratory from Australia. She recorded a presentation because of the different time zone, and she will be talking about testing for HLV, which is one of our challenges that we have in the response for HLV. So if Juan David or Leandro could share the video, that would be great.
Thank you for the invitation to speak today on World HTLV Day. It's a great honour to speak to you about testing. I'd like to acknowledge the traditional owners of the land from which I speak, the Wurundjeri people of the Kulin Nation, and pay my respects to all First Nations people who are here today, who are often may be affected by this virus. HTLV is over 10,000 years old, and this slide is showing where we've looked for it, where it's been tested for. There are slightly different genetic subtypes in different regions, and we know there's high prevalence in Africa and South America. It's found in Iran and Pakistan and the Middle East, and notably Japan, which is the country that's made the most progress towards elimination. Type C, or the Melanesian strain, is what we see in Central Australia, but has also been found across the Western Pacific, in Vanuatu and Papua New Guinea, Indonesia, and the Solomon Islands. It's likely right across the Western Pacific, but is largely untested. We use testing to make a diagnosis and to manage patients, and to stop transmission in a preventive measure through blood transfusion, organ transplantation during pregnancy, and also if we use mandatory notification, we can identify patients at risk by tracing their contacts. Diagnostic testing looks for evidence of infection by detecting antibody. And there are a number of very reliable HTLV antibody tests on the market. A diagnosis must be confirmed that the antibody is real and whether or not it's type 1 or 2. The Western blot, shown here on the right, is the traditional method for confirming a diagnosis, but it's not a great test. It has a level of failure which is problematic because people with an indeterminate result are left in limbo. It can't be confirmed whether they have it or they don't, which is very unsatisfactory. When you're trying to diagnose an infectious disease, you really want to go for the infective agent. This is hard for the HTLV virus because it only lives inside white blood cells, whereas antibody is sitting out in the blood fluid or the plasma, easier to access. HTLV virus detection needs a more sophisticated method, which is a PCR test to generate what we call a proviral load, which counts the number of infected white blood cells circulating in the bloodstream. You might recognise PCR as being that accurate testing that was used during COVID in the pandemic in the early stages. Graham Taylor and his colleagues in the UK undertook a systematic review of global data to show that a high HTLV proviral load test is associated with a higher risk for developing significant disease manifestations, while a low proviral load is not. But there is no commercial PCR test for HTLV available globally. And so as such, countries need to design and validate their own molecular tests. And to help build this capability, NRL, my organisation, as a WHO collaborating centre, has been working to support countries, especially in South America, to establish and be able to have confidence in their testing services. And we've established an international testing working party, which is successfully transferring knowledge from wealthier countries like Australia, Japan and the UK around the world. Our aim is to publish protocols and test methods to provide more cost-effective solutions and improve the quality and consistency of molecular testing through quality assurance. We desperately need reference material to help support those laboratories to know that their tests are working and that they can consistently know where their tests are performing well and that the tests are comparable across regional laboratory networks. There were many researchers from different countries that attended the International Retrovirology Association's conference in London of this year, and there's increasing evidence that some individuals with HTLV have successfully and effectively controlled the virus, which is great news. But it was also agreed that an HTLV PCR or proviral load test is very important to identify those patients at greater risk, but it's not specific enough on its own. We need better measures, prognostic biomarkers that can improve patient care by supporting discussions with patients about their risks, providing choices to patients, and supporting treatment decisions. I personally found the meeting very uplifting, and I've got a lot of renewed energy and passion to continue this work. And there was a very high level of interest and support for our testing working party, and as such, we've established another working group to solely look at prognostic biomarkers. And this work is going to support existing research programs in the area to work more collaboratively together to establish consistent biomarkers in two key areas: for early warning of the development of adult T-cell leukemia and lymphoma, and also HAM-TSP. So what have we achieved? We're working to address the inequity in access to testing services. And even for those services that are established, we're trying to help them with reference materials. There's a deep commitment to working collaboratively together and try and speed up progress in testing solutions to support better clinical care and treatment. And I'd like to thank the members of the testing working group and the IRVA board for their support. Thank you.
I would like to invite Dr. Monica Alonso, Unity Chief of HIV, STI, Hepatitis and Tuberculosis at the Pan American Health Organization, for the closing remarks from PAHO's perspective. Thank you, Monica.
Thank you, Carolina. I'm not sure if you can hear me and see me.
Yes, perfect.
Thank you. Well, good morning, good afternoon, good evening to all. We are so excited to see more than 400 persons connected to this webinar and to have jointly organized with WHO this event. So as Leandro has mentioned, and also Pamela Gaspar, that PAHO has launched the initiative for elimination of transmissible diseases. And Leandro showed how we are working to incorporate HTLV in the EMTCT+ component. We know that data in our region is scarce, but available information, and also Dr. Figueroa mentioned some data from Jamaica and from Haiti, but we know that while there is limited data, that there are some subgroups and some subnational geographic locations that have very high prevalence of HTLV1. And so while it is imperative to have a public health response for HTLV1, we also have to always bear in mind that this is also an equity issue because there are some subgroups that are very highly affected. So we're very happy that we're moving ahead in this joint, event to create more awareness. I think that some of elements that have been mentioned and I want to highlight is, on one hand, that we need more data. While there are some countries that have data, we need more to actually raise this in the public health agenda. We've all talked about the awareness, and I want to mention that for example, in our region, only 5 countries mentioned that there were civil society groups that work in HTLV1. So that is another very important area to push for, to have more groups working with the national health authorities to develop the interventions. And currently in our region, only 12 countries have informed us that they have interventions for PMTCT for HTLV1. So the awareness component is extremely important. We also heard about how WHO is working on the development of guidelines. So this is the other aspect that I would like to highlight. It's extremely important. While there's some countries that are working, such as Brazil, we have Chile, we have Colombia, we have countries in the Caribbean that are already testing, for example, all pregnant women or have policies to do so. That is another area that with these WHO guidelines, it would be an important aspect to move forward in having these public policies. And lastly, I don't want to end without mentioning the research. There has been some examples of research, but we need more research for interventions for treatment, in addition to the element of testing and prevention. So I think those are some of the basic aspects that we together are trying to move forward. PAHO definitely is committed to having a more broader regional response, and with our champion countries such as Brazil, with the Brazil Saludable, we're hoping to have more countries on board, and all the countries that here are mentioning in the chat also their interest. We are hoping to join other countries in the world, right? But to have a strong regional response for HTLV1. So thank you very much for the opportunity to say some words.
Thank you, Dr. Monica. Now I would like to invite Dr. Meg Doherty, Director of Global HIV, Hepatitis and STI Program at WHO.
Well, thank you very much. And it's hard to follow all the excellent speakers and presentations and add something new. And I just want to say it's an important moment, I believe, for all of us to actually, for the very first time as WHO and PAHO together, to be commemorating together HTLV1. And or HTLV infections writ large. And I feel very much that not only have we heard from an excellent panel, from all representing all parts of the world, it's in a moment to be reflective, to think about what we haven't done in public health to be able to address HTLV1, and to feel inspired and motivated by the life story of Fatouma Diallo, and thank her for sharing this, where an entire family has been touched by HTLV1 over many decades, and where we note that fear and stigma has left many people behind in the response. So we know that, and what we've heard is that HTLV1 is a public health problem, and that the response has been limited and mostly focused on screening, from blood donations, and now really seeing this groundswell of response coming from the Americas, coming from Japan, and coming from Brazil. And we need to make this more of a standard part of our public health priorities. In 2020, WHO shared the first WHO HTLV1 report, and we also laid out 12 actions that we needed to take forward to address these gaps, whether it's in research, guidelines, implementation, and response to HTLV. It has also been included as part of our global health sector strategies for HIV, hepatitis, and STIs from 2022 to 2030. So in many ways, now we have a member state endorsed strategy and also regional strategies that have included HTLV1 and HTLV as part of our priorities. So as we're moving forward, which we've heard around the technical group meetings and the guideline development process, we're going to be leaning on you and hearing from you to give us the best advice, the best science, the best lived experiences. We'll be focusing first on testing and diagnostics, as well as how to and what are the standards for elimination of mother-to-child transmission. But we don't need to stop there. So we want to thank you for your commitment and your concerns, and please help us as we do more for this neglected area and neglected infection. So with this, I want to thank all of you and say, and just recommit, like PAHO has recommitted to, this is part of our priorities, and we're glad to be able to commemorate this day with you. Thank you.
Thank you so much, and thank you everyone for joining us. So we will be sharing the link for the recording and also the video from Dr. Filippo Hetzel with the email that you registered today. So thank you everyone.